Okay, it looks like most of the people are here now. Hi, I'm Sharla Glass. I'm with Envision America. I've worked there for about 17 years now, and we do accessible prescription labeling. So we partner with pharmacies to provide audible, large print, Braille, and translated prescription labels. And I'm happy to be here today because I think that a lot of health literacy really starts for a lot of people with their medication labels. And if you don't have access to reading the print on your label, it's going to be a big deal. Personally, I'm also been really interested in all the presentations. I have 6 children and they have a variety of non-communicable diseases and mental health issues. And so I come at it from a very personal approach as well. Today, I'm going to talk a little bit about mental health and medication management. And we're going to talk about counseling at the pharmacy counter, risks of inaccessible prescription labeling, how to do an assessment or just what to supplement to the assessments you're already doing, what accessible prescription labeling formats are available, some of the best practices, and then just an overview of the public policy scene right now. And then if we get to it, we'll talk about participating pharmacies and advocacy. So just as a little introduction, as far as putting accessible prescription labels into the mental health and health literacy field, we have recently the advent of pharmacogenic testing for mental health patients. So we can have the genetics lead us to what medications might work best. But even with that, you're going to try several medications before finding the one that treats the symptoms with the minimal side effects. Consistent adherence is imperative for optimal results. And like so many people have said already, and in the last presentation, adherence isn't always about the person's willingness, but the overcoming the barriers. So, being able to read your medication labels might be one of those barriers. And then many drugs require changes to dosage or timing, which results in patients having multiple prescription bottles on their nightstand with varying dosages and instructions, old meds, expired meds, all kinds of stuff going on. And if you don't have the ability to read the expiration dates, the refill dates, the dates they were filled, which one was filled first, which one did I get next, all that goes into play. And I'm saying this like as a mother who is sighted and can read English perfectly, it's a challenge. So I know there's a challenge for, and I hear this anecdotally from our customers all the time, it is definitely a challenge for people who are visually impaired. I just had someone 2 days ago telling me, I was trying to manage my daughter's medication. She was suicidal. So she was 12 and suicidal. She had to have all the meds locked up. This blind mother was trying to manage her meds. The pharmacist, handed her a bunch of bottles. And she was like, it was such a challenge. And she was like, I really didn't want to rely on my daughter to read the medication labels because she was in an unreliable state. But so at times I had to. And so, it's just a really dangerous circumstance. And we want to be able to manage those meds the best possible. A lot of the time, when people are visually impaired or have limited English proficiency or learning disabilities, illiteracy, they really rely currently on the pharmacy counseling, on what their doctor tells them, and then on the pharmacy counseling. The challenge there is that counseling is very perfunctory, and often clients decline it. So they're like, oh, do you have any questions about your meds? That's a very yes or no question. And they're probably, even if they have questions, they're not going to think about them right now at the counter. And even if your questions were answered, a lot of people have limited memory. When they're at the pharmacy counter, they're not feeling well. They haven't taken their meds yet. They might have limited English proficiency. They might be deaf or hard of hearing and not really be able to hear what you're telling them. perhaps someone else picked up the medication for them. So they weren't even really there to ask the questions or to hear the answers. And I mean, if it's like me, again, I don't think of the questions till I'm home. And I'm like, oh, was I supposed to take this one at the same time as this one or a different time? How are we tapering this? Like that's going to go all the way back to the doctor. And a lot of those tapering instructions aren't even necessarily put on the medication pill bottle, but they are information that you need to talk with your doctor about and or the pharmacist, because that goes into like how long is your medication going to last? Are you cutting it in two? Do you need two different amounts, like sizes of medication and so forth? When it comes to the printed label, say you had some really great counseling, but you get home. If you have a vision impairment, you might not be able to read your prescription labels. One thing that we don't take into account a lot of the time is that not all vision loss is permanent. Some people have fluctuating vision loss. For example, if you're diabetic and you have very high blood sugar today, you might have fuzzy vision today or tomorrow, but it's not fuzzy all the time. You might have progressive vision loss. So slowly over time, people lose their vision. And so in that case, you know, they might not even realize how much they're losing, and they're constantly just trying to compensate in other ways, like holding the bottle closer and closer and whatnot. There are also other print impairments that aren't really vision related. For example, dyslexia or a traumatic brain injury, or maybe even a vestibular issue where you feel like you're dizzy all the time. It's kind of hard to focus then. And of course, illiteracy. If you haven't really learned to read or you don't read well, then you might not understand what you're reading or misread it. And then a lot of the medication bottles are just difficult to navigate. They're just not designed that well. You're trying to get a lot of information into one small little area. And so that's another thing. And I know there are a lot of studies that have been done. I know Wisconsin Health Literacy has been working with pharmacists in Wisconsin to improve labeling. And I know there's a lot of other ventures out there to improve labeling designs. But that's something to take into account. Sometimes the labels are just missing information. Not every state requires the indication to be put on the label. So people don't really know what their medication is for. So, you know, is this my heart med or is this my cholesterol med? You know, sometimes it's really helpful for that indication to be put on the label, and it's not always put on. And then sometimes the directions are just easily misunderstood. And so again, that could go to the labeling design or the way the SIGs are, which SIG you decide to put on the bottle. You know, whether it's telling you like, take 2 every day. Do you take 2 in the morning? Does that mean you take 1 in the morning and 1 at night? So sometimes the directions are vague and people don't understand them. And that's all assuming that you can read the label. So some of the risks that come from inaccessible labeling include medication errors. Maybe they're unaware of the warnings, like don't eat this with grapefruit. We had one patient that, you know, that's what he found out, that he wasn't supposed to eat it and it was destroying his liver. So that was one of our very first script talk patients. Or you could take an overdose, or maybe you didn't know that you were going to get drowsy, and then you're in a situation where you're getting excessive drowsiness and you didn't know that was one of the possible side effects, or you shouldn't drive or whatever. Although if you're blind, you shouldn't be driving anyway. But, you know, again, if you have one of these other issues where you have a print impairment, but not a vision impairment, you could be driving still. You could be just unaware of the normal side effects, not know how to properly store your medication. Some medications need to be refrigerated. Some need to be stay out of sunlight, and that kind of thing. And again, I already mentioned expiration dates, refill information.
Excuse me, Sharla.
Yes.
Do you have any other slides other than the opening slide?
Yes. Is it not working?
No, it's just showing the first slide.
Okay, I thought we figured this out. Shoot. Well,
Mario, can you navigate?
Yeah, let me take a look here.
let's try. Let's try if we choose this one and just go this route. Can you see it now?
Yes.
Okay, well, we're just gonna go this route. It's not gonna be as pretty, but so here's what I was talking about. The pharmacy counseling, printed labels, and risks of inaccessible labeling. And then, so to finish up this other risks, if you don't really know what you're taking, you could have stress and confusion. And so a lot of times people will choose not to take their medication. We are working with nurses in Oregon, and they said, we have patients that don't speak English, and they just chose not to take their medication because they knew that medications can be dangerous if you don't take them correctly. So they said, well, I figured it was safer to not take them than to take them incorrectly. So that is another issue. So then when we think about our health literacy assessments, I know most of you already are doing certain assessments with your patients, but something to consider when it comes to medication labeling is assessing the reading level, which a lot of health literacy assessments already include, English proficiency, and then adding this vision assessment. How much can they see? How often can they see? Do they have, fuzzy vision periodically? Or, are they consistently using some kind of assistive device like my brain fog there. But are they using glasses or anything else to help them? That are there any comorbidities that might impact vision? So we already talked about diabetes, macular degeneration, glaucoma, and what format will best meet their needs. So I've had this conversation many times. There's people who are like, well, I know I really want a Braille label because I don't even have to get any other devices out in order to read the label. Any of them, their second choice might be an audible label. But other people are like, well, my first choice is large print. And then my second choice is Braille. My third choice is audible. So really people have different choices based upon, their ability to access the information and their obviously if someone's lost their vision at age 79, they've never learned Braille. They're probably not going to learn Braille at age 79. They're going to want, an audible label. And then when we're talking about social determinants of health, there's other things that go into, whether you can get your medications or get them frequently enough and everything. So is there limited transportation to the pharmacy and the doctor? So that includes public transportation, pharmacy deserts. For a lot of the blind customers we work with, can they even get a ride? Maybe they don't have public transportation. I have one customer, they're like, well, we don't have public transportation and there's no Uber. Like no one's signed up in my town to be an Uber driver. So how do I get there? She has to rely on friends and neighbors and just to get to the pharmacy. And so just getting the prescriptions can be a big hassle. And then once she gets them, can she read them? Limited job opportunities and income. So your income might change, what prescriptions you're going to get. Are you going to get the generic or not? Are you going to just forego some medications? Limited insurance options, again, same thing. Social isolation, we heard this a lot with our consumers. during the pandemic. And I mean, I know a lot of people did, but especially blind people, because they were so reliant on other people driving them places or coming to their home to read their mail or help them organize their groceries and stuff like that. And then lastly, limited access to technology. A lot of blind people today really rely on technology. There's amazing technology, screen readers, the iPhone voiceover, allowing them to use apps, seeing AI and IRA and other services that tell people what's in front of them and can read them text and stuff. But if you can't afford a smartphone, if you don't have a smartphone, if you haven't been trained on how to use one, if you don't have a computer or accessible software for your computer, all those things, make it harder to access your label information, access patient portal, to ask your doctor or your pharmacist about your medications, making refills and all that kind of stuff. So all that goes into it. Now, I've talked a little bit about the various different labeling options. So these three in the center are what our company offers. We have the large print label, which has enough room to have multiple languages on it. We have our app, which can read our script talk labels. And then we have the script talk device itself. So the RFID tags for script talk can be read using the app or the script talk device. So we have both the smartphone and the low-tech version. And those are available in multiple languages. We have pharmacies that are offering the translation service, and we have about 25 different languages that are available for those who are doing the translation service. And then you can see some of the other solutions. In the top left is a sample of a Braille label. The bottom left is a sample of the CVS Spoken RX, which functions the same as Script Talk, but you use the CVS app or the CVS Spoken RX device. And then on the right, we have the talking pill reminder. That is Walgreens' solution. And then on the bottom right, there's still some pharmacies that are using this talking RX device. And both those on the right is you audio record with your own voice. The Script Talk and the Spoken RX are a digital voice. I'm gonna skip these video demonstrations for right now because for time, if we have enough time at the end, we can come back and look at those. But they're all of this samples of how these devices work are available online. In 2013, the FDA Safety and Innovation Act was passed, and one little line in that act was that Congress asked the U.S. Access Board to create some best practices to help guide pharmacies in providing accessible labels. So these large print Braille and audible best practices are actually published by the U.S. Access Board, and they have them kind of fleshed out on their webpage. But basically, for a large print, we're looking at 18-point bold font as the minimum. Sans serif font, again, that's usually the best one for anyone who's dyslexic or has vision issues. It's an easier to read font. 1.5 point line spacing, non-glossy paper. A lot of people with visual impairments, the glossy things and light play a huge part in what they can and cannot see. And going along with that, high contrast, as much contrast as possible. Using sentence proper case, using all capitals is usually pretty hard. It makes it harder. And then only using horizontal text, so it's a lot harder for them to navigate if the label has lots of different ways of having to read it. For Braille, most of the time they recommend the contracted grade 2, that it should be a clear overlay so that you can still see the legal label. And again, that's going to be really important if you have healthcare workers coming in to assist you at times. A strong adhesive so that label doesn't fall off. Same thing with don't fold it, because then the dots are not legible anymore. If you have a crease at the same place as a dot, you can't feel it correctly. And then an option for electronically delivering information to a Braille display equipment. So a lot of people today who read Braille will have a Braille display or a portable Braille reader that they can hook up to their phone or computer. So if you can send that information digitally to them, they can use that device instead of having a huge stack of Braille paper transcribing something. And then for audible solutions, they really recommend having a stop function so that you can start and stop wherever you want. You don't have to listen to the entire thing. And that's also kind of a HIPAA thing. Volume control, earbud access, again for HIPAA, a clear voice, minimal background noise. So if you're audio recording and there's like lots of stuff in the background, that's going to be harder to hear. And then the dual language best practices that I have listed here are really based upon the nursing students in Oregon that I talked about, and some of the conversations we've had with the Oregon Board of Pharmacy, the Nevada Board of Pharmacy, and the Washington Board of Pharmacy as they create rules. So the first one is provide directions and warnings in English and the preferred language. So both the patient and emergency medical personnel or healthcare assistants can read the label. So, if somebody calls the ambulance, they need to be able to read what the medication label says as well. So it can't only be in a foreign language. Translations should be on or securely affixed to the container so they're not separated. So the nursing students found often like these patients were given translations, but it was a separate piece of paper than the meds. And then they get home and they're like, I don't know which paper goes with which med. Like, it's just a pile of paper now. And then any additional leaflets should also be in the preferred language. So if there are a lot of instructions or a medication management plan, it should be offered in their language as well. All right, I'm going to head into the public policy timeline here. So this is just a quick overview for those of you who are interested in the public policy side of this. Obviously, as far as dual language translated labeling, we're going to go all the way back to Civil Rights Act of 1964. And as far as labeling for the blind and visually impaired and others who are disabled, we have the Rehabilitation Act and the ADA in 73 and 90. So, those are all a long time ago. And yet we really don't have consistently having pharmacies provide accessible labels today. But a lot of that's because of the technology. It's just been developed in the last 15 years, 20 years. So, it takes time for people to adopt it. And then in 2000, there was the Executive Order 13166, where all anyone who gets federal money has to provide translation. So that was really the first time that it would even be considered in healthcare that they were required to provide translation, as far as I understand. In 2010, we had the Affordable Care Act and its Section 1557, which kind of changed the landscape because it required anyone receiving Medicaid or Medicare monies to provide accessibility and non-discrimination. So we really saw a lot of pharmacies asking us for solutions at that point in time. In 2012 was the FDA Safety and Innovation Act, which again required the U.S. Access Board to create those best practices. That was also the same year that New York introduced a translation law for pharmacy labeling. In 2015, California introduced a translation law, and both of those are limited in scope. They're not required to do every language, and not every pharmacy is required to do it. So in New York, it's limited to chains, and in California, it's limited to 5 languages, I believe. In 2017, Nevada was the first one to do anything with accessible labeling for the blind. They required pharmacies to tell people that it's available. It didn't actually make them have to provide them, but they had to tell people where they could go to get it. And then 2019, Oregon actually passed both an audible labeling law and a dual language law in the same year. So that was really impressive. And those nursing students that did, they did the entire kit and caboodle. They wrote the draft language. They presented before the congressional or the legislative committee and everything, and really went to bat for their patients. And I was so proud of them. And they even the legislative committee like gave them an ovation at the end, saying it was like the best presentation they've had for a bill in a long time. So they did a really great job. And then at the same time, the American Council of the Blind of Oregon was working on the dual language law. And so it segued very well because they shared a lot of the same arguments and concerns. And then in 2021, Nevada had added the dual language law, and we're hoping next week that finally is finalized with all the rulemaking, and that will be going, being fully implemented after next week. And then just this year, Tennessee passed an accessible labeling bill for the blind that has moved to the Board of Pharmacy, and they're going to start the rulemaking and talking about what that's going to look like in their state. And then Washington had a bill that did not pass, but their Board of Pharmacy really understood the need for the dual language and accessible labeling in Washington. So they're starting rulemaking as well this year. And they actually just sent out a survey today to all their pharmacists asking, what do you do already and what should we do in the future, and what are some of the barriers and what could make this more easy. So it'll be interesting to see what comes back from the pharmacists on that. So just a little bit about scriptability participating pharmacies. Not every pharmacy does every solution. So that's the first thing I want to say, is that the pharmacies get to choose which labeling options they provide. Obviously, it's the free countries. They can pick our solutions, they can pick other solutions. They can currently claim an undue burden and not provide any solution, depending on your state law. But we offer large print, Braille, audible, and translation. And our translation is available in the audible label or in the print format. Pharmacies also choose how they will provide it. So we encourage them to provide the labels same day at the counter. Not all of them do that though. Some do it via mail order. So, they might have retail pharmacies, but if you want an accessible label, you have to have it mailed to you. Some will do it like a regionally. So they'll have like one pharmacy in a 20-mile radius, and they'll service all the other pharmacies. So they'll deliver it to your home or mail it to you, but from locally, not from someplace far away. A lot of places, they don't set up their pharmacy until you ask about it. So like a Walmart, they don't have the equipment in every store right away, but if you ask for it, they'll get it all set up in a couple of days for you. And then, so some do it in every store, some don't, some do it regionally. On the left, these mail orders that I listed there, they're currently offering all the solutions. So Aetna, Caremark, Express Scripts, Humana, Optimarx, and Walmart, they actually all offer translation. They all offer an audible solution, a Braille solution, and large print. So anyone can, if they're a customer of one of those mail orders, they can call today and get the solution. They just have to ask for it. We also have worked on integration with other pharmacies. So here's a kind of a picture of a lot of the different software companies that we're integrated with. Our software can stand alone. They don't have to have it integrated, but if they want to integrate it to like have a more seamless flow in their pharmacy, that's an option. There is just some little details that like these are commonly asked questions. A script talk device can read a script talk label from any pharmacy, no matter what pharmacy you get it from. So you can use OptumRx for your maintenance meds and then get an acute medication from Walmart, and you can still use the same device to read both those labels. CVS retail pharmacies, I mentioned they do spoken RX. Their home delivery and mail order use script talk though. So the spoken RX labels function the same way as script talk, but they just have slightly less capacity for data. So patients can request a spoken RX device if they don't want to use the app, and it will read spoken RX and script talk. However, if you have a script talk device, it's not going to read spoken RX. So because they wanted the capability of reading both, and so we gave them permission to read our labels, but it doesn't work the other way. And then Walgreens, I showed that they had the talking pill reminder, and I just want to give a caveat on that because a lot of their pharmacists don't really know that that's their official solution. So they sell those in their pharmacy, and what we've been told is, you know, if someone needs one, they'll pull it off, and then they don't charge the customer, the blind customer or whatever, to use that on their prescription label. But a lot are not familiar with that. So there might have to be some advocacy if you really want that Walgreens solution. And if you really need information on that, I would just Google it, like Walgreens talking pill. Lady Feingold was the lawyer that did the settlement agreement a long time ago, and so she still has information on her website. As far as advocacy goes, and I have only a very little time left, so I just want to say, you just a focus, like you do have the right to these because of the ADA and the Affordable Care Act. You do have to ask. You do have to follow up. I mean, like you tell a pharmacist, the pharmacist says, oh, I got to check on that. We'll tell them, okay, I'm going to follow up on this day and do that because they have a lot on their plate. Don't expect them to call you. You have to do the follow-up. You can make a difference by asking pharmacists about this, by talking to your legislators, talking to your pharmacy board. You know, we just need to talk about it more because, you know, we do have the ADA and Affordable Care Act, but the state is the one that really looks to see if pharmacies are doing what they're supposed to do. And most of the states don't have a matching statutory law. And I just want to extend that we can do the work for you. If your patient needs help finding a participating pharmacy or some help with advocacy, we are here. We have really amazing customer care team. And then more advocacy resources are available at staysaferx.org. That is kind of a blog, and they put out, you know, they keep track of all the laws that are being passed, and they have like, you know, a blog like what's going on lately in the world and stuff. So about patient advocacy and stuff. So here's my contact information. Feel free to call me if you have questions or visit our website for more information about our labeling solutions. I know there's more labeling solutions out there that I did not cover. Pharmacies are very creative in trying to accommodate their patients. So I'm sure there's something else out there, and I'd love to hear about it if you know about it. So, all right. And then I'm going to go over here and look at the questions. Are there options for hearing impaired that might not be literate? I would say yes. There are some, but it is definitely a challenging place. Depending on how hearing impaired they are, I know that a lot of people have used our script talk with earbuds and said it really worked well with them being able to adjust the volume and everything. If they're, yeah, That's a hard one. I know like we have like solutions where it goes to the Braille, but if they're hearing impaired and not literate, but also not Braille literate, that's definitely a bigger challenge.
Is there sign language that could take the, um, be done video?
Yes. Yeah. I mean, that's always an option, to do a video, to record a video for them. Yeah. We don't have that built into our app, but you know what? I'm gonna write that down as a as an idea. The hard part is if they're hearing impaired, but they're elderly, so they never learned Braille or to sign. Then that's a really, really hard place to be. How can we advocate for pharmacies within hospitals that are federally funded? Well, if they're federally funded, they are mandated to provide accessible labeling, really. So it shouldn't take too much advocacy. There's lots of ways, like if they're not willing to discuss it with you, you could always file a Section 1557 complaint form with Health and Human Services. That'll get them going, I'm sure. But yeah, definitely I would talk first about health literacy and health equity. And then if that doesn't do it, yeah, you could always go start filing complaints. And if you want to talk more about that, like one-on-one, we can do that, call me.
Sharla, how can this information be available to, people who help the patient but are not at the pharmacy? Could be case managers or care workers. How do they get access to some of these tools or these resources that you mentioned?
The case managers.
The case managers or care, like community care workers?
Yes. I would say, like, you can go to envisionamerica.com. We have an advocacy page. I also have another web page that I kind of just put together myself. It's my Let Us Do the Work For You page, and you can just email me or call me, or go to envisionamerica.com and fill out the request form. We can send you a link to that. We actually have a patient request form that advocates can fill out and send to us. You can send it by email or fax or however you want to. And then we reach out to the patient and help them. We ask them all the questions like, what pharmacies are open to you? What are your options? What are your limitations? What languages do you need, etc. And then help match them. And, we always encourage people to do their ADA requests first. Like, you talk to your pharmacy first, and then, you can tell us that you talked to them, and we can send them more information and follow up with them and like get our sales reps to like talk to them and answer all their questions. That usually seems to work well. Because the ADA kind of does have a method, like you need to request it. And then at least you did that initial, like you did your part, and then it's up to them to like match it. And then you're justified in, having a complaint if someone doesn't honor your request. So.
Thank you, Sharla. And everybody, if you have any more questions, you have Sharla's email address. You can email her directly.
Yeah, happy to.
We'll be posting her presentation, and our next session is going to start in about 3 minutes. Thank you, Sharla.
Thank you. Have a great day.
Bye.